Hi, this is Dr. Bob Dannenhoffer, Public Health Officer for Douglas County. It's February the 2nd, and this is another of our Facebook Lives. This is about our 100th one that we've done over times. And just like the movie Groundhog Day, it's beginning to feel a little bit like Groundhog Day, talking about the same things again and again. But there's a lot changing, and because there is a lot changing, we will go through it today. As always, this is your chance to ask questions. We've already had a few questions in our Facebook questions at douglaspublichealthnetwork.org mailbox, and we'll go through those first, but please put your questions in there. Kristen and Vanessa will go ahead and collate them, and then I'll look at them. So sometimes we get a thing like, oh, Bob, you're not looking at all my comments. Well, I'm not seeing your comments here. I'm seeing what Vanessa and Kristen send me. I will respond to comments later on tonight, but again, put them in the chat and we'll get to them. As we always do, we'll start at the world level, and the world level is 103 million cases, 2.2 million deaths. I really think the number of cases, the number of deaths over the last 2 weeks is beginning to flatten and decline. Still, though, a very active disease in Portugal, Spain, Israel, Czech Republic, and the UK is beginning to quiet. Brazil is interesting because there's a place in Brazil with lots of disease and other places without much disease. The places in Brazil that have a lot of disease are a little concerning. These are places that had big outbreaks before, especially in the Amazon, where we think as many as 3/4 of the people had the original disease. There's now a new variant there, and even people who clearly had the disease before are getting it again now with the new variant, and they seem to be getting very sick and even dying from this new disease. So that is a very, very, very scary part of Brazil. In the US, we're at 26.4 million cases, 444,000 deaths. We really have shut up this month. Again, December 2020 and January 2021 are going to be two of the deadliest months. In the U.S., we're seeing declining case counts. We're beginning to see declining deaths and declining hospitalizations, and that is so great because it was really looking pretty terrible at the beginning of the month. The hotspots in the country, pretty much overall cooler, but we're still seeing real hotspots in Texas, in South Carolina, Arizona, places in upstate New York that previously didn't have a lot of disease. And so we're still seeing some hotspots, but overall considerably quieter than it was before. Oregon continues to be one of the quietest places. We have the second lowest rate of cases over the last bit, the fourth lowest rate overall, the fourth lowest death rate overall. We're at 143,000 cases and 1991 deaths. In Douglas County, we're at 1,864 cases and 48 deaths. We're about 10 cases a day. Again, still one of the quietest big counties in the country. And so that's a good thing. We're seeing a bunch of cases at schools, although we're not really seeing any transmission in schools. You know, a kid will come in or a teacher will come in who are positive. We quarantine everybody, but we've not really seen lots of secondary spread, so that is a good thing. We've got no big outbreaks, and that's why I think our case count is low, but the news today showed a big outbreak in the jail, 24 cases, in the jail in Josephine County, and their jail's just like our jail. So there's nothing to say that we couldn't get this kind of cases here. So again, we're asking people to be careful. We're asking people to be safe about that. Well, the big news is about the variants, and the variants, again, are mutated viruses. And the concern on these mutated viruses is, will they be as well killed or well prevented by the vaccine? Looks like it may not be. Some of the data from China suggests that the South African variant the vaccine may work, but not quite as well. And then that story in Brazil where people 8 months after their first infections are now getting a second infection with the Brazilian variant is really quite worrisome. In the US, we've had scattered cases of each of the variants, more of the UK, a few of the South African, and now one of the Brazilian. And so we'll see what happens there. But that's the real concern, is that if these variants spread and people don't have immunity either because they have the disease or because they had the vaccine, that will really be terrible. And I know there'll be a lot of questions about vaccine. So let me pull up the questions that people have had, and we'll go through those. All right. So Tracy says, is the second booster of the Moderna vaccine the exact same ingredient, strength, and amount as the first dose? And yes, they're identical. So first dose and second dose look exactly the same. There's no difference. There's no difference between them. Amy says, would I address the hydroxychloroquine issue again for people who keep wondering if it's a wonder drug? Well, so through this pandemic, there have been a lot of different drugs, over 40 drugs that have been suggested to be effective in this pandemic. And that's how things go. You know, you're looking at things, you make an observation, then you test out the observation and see if it works. So there is absolutely no harm in making an observation that you later test. I mean, this is the way that most of discoveries in medicine have happened. So it's not like Alexander Fleming said, oh, I figured out penicillin. What happened is he was apparently a sloppy scientist and left out a tray, petri dish, and on the petri dish, some mold grew. And when the mold grew, he said, it showed that it stopped the growth of the bacteria. And he said, well, that's odd. I wonder if you could purify this mold and stop bacteria. And thus penicillin was born. It wasn't like he was looking for penicillin at the time. He just happened upon it. So similarly, when we learn about how drugs work or how vaccines work, frequently we'll happen upon something and then think it might work. So hydroxychloroquine is an interesting drug. It modulates the immune system. It also treats some kinds of infectious disease like malaria. So, I mean, it's one of the drugs we use for malaria, and we also use it for arthritis because it modifies the immune system. So, not at all an unreasonable thought that it might work. And in fact, early on, the Chinese, when they, first in January and February, when they didn't know anything about it, they actually tried hydroxychloroquine for some patients. They tried a bunch of other things. They tried some AIDS meds. They tried some flu meds. They tried a bunch of different things that would work. They didn't see much effect of this. In the U.S., then it got kind of this folk following that hydroxychloroquine might work, and it became very politicized. Right? You usually don't hear politicians talk about one drug versus another. I've not heard politicians come out and say, boy, penicillin, amoxicillin is better for ear infections than trimethoprim sulfa. I mean, it's usually not in the political realm, but this one really got in the political realm, and it became a political place of belief. For me, it was like, politically, I don't care one way or another. The question is, does it work? And what we did then was a bunch of really good double-blind studies where some people got the vaccine, some people didn't, same populations. And unfortunately, what they showed is they didn't work. Now, there were some observational studies that suggested it might work. So the observational studies were, hey, Dr. So-and-so uses hydroxychloroquine. This other doctor doesn't. This doctor seemed to have lower mortality. But in those cases, the populations were different, the exclusions were different. And when you corrected for all that, it shows that hydroxychloroquine doesn't work. So what does work? Well, the thing that we know best that works is Decadron. So Decadron, a very old steroid, something we use all the time in pediatrics for croup. It actually works great for croup. One dose, it works great for croup. And so we know it's a good anti-inflammatory drug. And we found then through a double-blinded study that Decadron really does work to decrease both death and hospitalization and days in the ICU. So it really works. Remdesivir, which is an antiviral drug, works a little bit. I mean, it does decrease your number of days in the ICU, not striking on death. The monoclonal antibodies, which are given by infusion, if given early on, do seem to decrease your risk of worsening. And so they've been approved and they use. Convalescent plasma, remember where you draw it from somebody who's had it, has really not been great. I mean, it may have a slight difference, but it's really not magic as it is for other diseases. Pepsid, which is an antacid, was shown early on. Again, the data is not there. Ivermectin, an antiparasitic drug that there are some people who really feel strongly about. It's got some scattered studies showing that it works or not works. I don't know. I think that the jury's not in yet on that. There's Luvox, which is a drug that people use for obsessive compulsive disorder. Again, the way this starts is in France, people note that the patients from a mental institution who were on these drugs got sick a lot less than the staff who weren't on the drugs. And so they wondered if there was something there. And there's this sigma-1 receptor that they worked on. And it does look like Luvox probably does work. There's a reasonably good small double-blind study that showed that it did prevent progression. So hydroxychloroquine, I wish it worked. It doesn't seem to. Ivermectin, I wish it worked. I still don't know. Luvox, I wish it works, and it looks like it might. And so there's all these different things out there. We talked about one on Friday about a drug from sea squirts that seemed to work in the laboratory. But again, working in the laboratory and really working in people is quite a different thing. Okay, so please speak to the recent post by Dr. Tim Powell about masks. Well, so I think I'll start by saying well-meaning people can look at the same data and disagree. And so I think this is a case where Tim, who I know very well and talk to him all the time, kind of disagree about this. I think the story is that masks are neither the panacea that somebody suggests, like, oh my God, just wear a mask and this would all go away, nor are they totally ineffective. I mean, we do wear them in the hospital when we have a sick patient, and we do think they prevent some disease, otherwise we wouldn't wear them in the hospital. But they are neither the panacea that if we just wore masks, everything would be better. Masks are just one of the tools that we can use. So social distancing, staying home when you're sick, wearing masks, all work. Some of the data that was in there is old data, what Dr. Fauci and Jerome Adams, our Surgeon General, said in February and March, a little less clear. The Danish mask study was real. We've talked about that in the past, was really underpowered to show big differences. What it did show, so that study gave some people masks and didn't do anything to other people, and they found that the people who got masks had a slightly lower rate of disease than the people who didn't get masks. But the problem was there weren't enough people in the whole group to know whether it really did that, and many of the people who were given masks didn't wear them, and some of the people who weren't giving masks went out and bought them. And so that there wasn't that much difference in mask usage between the groups. And the study was underpowered. So it's one of those studies I think you don't know. But that was the only one that would try to be a controlled study. But some things you can't control. So double-blinded means the person doing it doesn't know whether they're getting the drug or not, and the person who's evaluating doesn't know if they're using the drug or not. And so you can do that with a drug thing because you give some people a pill that could be hydroxychloroquine or a pill that could be a placebo. Unfortunately, with masks, it's pretty hard to do a double-blind control study because obviously somebody can tell if I'm wearing a mask, and I can obviously tell if I'm wearing a mask. So it's hard to do those studies. So I think I will leave it that well-meaning people will disagree. Now, one of the things I will point out is that he was saying, Sweden has done a good job. I would totally disagree with that. If you look at Sweden and compare it best to its neighbors, so if you remember Scandinavia, there's Sweden in the middle, Norway and Finland on both sides. Pretty much similar countries, but in this case they've taken a different approach. Sweden has taken a more laissez-faire approach. Norway and Finland has taken more of a European approach. And the difference in outcomes is enormous in the number of cases, the number of deaths. So Sweden has about 10 times the number of deaths per million, as does Norway and Finland. And so I really do think that the Swedish story is cautionary, that yes, you can use less masks, but then yes, you will have more cases and you will have more deaths. Similarly, in the United States, there are places that have really been a little more stringent about masks, like Oregon, and again, we have a very low rate, and then other states in the country which have not been as stringent, like the Dakotas and like Georgia, and they have a lot more deaths. So you remember we've done this doppelganger thing since August. It's hard to believe it's 6 months ago that we first did that doppelganger thing on that beautiful map. And again, the doppelgangers look at 4 similar counties around the country. And these really were carefully picked to be similar. They're each in the same 100,000 range. They're each not big urban centers. They each have a mixture of employment. And so they really are not exactly the same, but pretty close. And when we look at that, Douglas County's had 48 deaths, although we have far and away the oldest population of the 4 counties. So you could say, well, maybe you got fewer deaths because you've got a younger population. No, we've got far and away the oldest population. Twin Falls, 100. So we've had 48 deaths. Twin Falls, 120 deaths. Pennington, which actually has the youngest population because there's a military base there, has 170 deaths, and Lowndes County in Georgia has 165 deaths. So we've got, a quarter of the deaths of the highest counties, a third of the deaths of Twin Falls. And so masks, I think, do make a difference. But again, I work with Tim all the time. He's doing an incredibly good job at his clinic of vaccinating people, seeing people who are sick. So there are no personal disagreements. I think I would say on this that well-meaning people can disagree. So Carol says, I've read that many have suffered strong adverse reactions to the Pfizer-Moderna vaccine if they've already had COVID. So the new report today suggested just that people who've had a recent infection can really get quite the reaction to the vaccine. And again, this is not surprising. Remember, those reactions to the vaccine are your body mounting an immune response. And we think after you've had the infection, your memory cells at least know you've had this infection and are ready for it the next time, so that now when you get this injection, it really goes after it pretty hard. So Paul says, I'm having a hard time understanding why some people don't want to be vaccinated. Can you give us a primer on how vaccines work to help us explain why they're important? Well, so when a disease like this comes by, there are two ways to become immune to it. One is to have the disease. The advantage of having the disease is very natural. The disadvantage is about 2% of the people who have the disease die. So that's pretty high. The other way to do it is to do the vaccine. And what the vaccines do is they have your body make a protein. When the mRNA vaccines, for the Nova vaccine, it actually injects a protein. And then your body makes a reaction to it. And the reaction to it is to make its antibodies. Those antibodies there then are waiting for the next time your body sees this virus and then makes a reaction. The reason people don't want the vaccines vary. Some of the people say, well, I just don't want to be the first person getting it. I want to see what happens with everybody else. That's a common thing and pretty explicable, right? I mean, when something is happening that's new, you may not want to be the first person to try it. You might want to see if it works and whether there's troubles. Be it a new restaurant in town, right? You may not be the first person to flock to the new restaurant, but when other people go and they say, hey, it was pretty good, then you might go. Or if they say, oh, it was the worst place in the world, you wouldn't have wasted your money in going. So there's some of the people who are not wanting the vaccine are wait and see people. I know a lot of those. I think wait and see is an incredibly human characteristic. We don't have any troubles with that, because I think the wait and see people, once they see, they'll hear that this is a great thing and they'll get it. There are some people who just don't want any vaccines because they don't want to introduce into their body anything foreign. I see that a little less because really vaccines are an amazing thing. And there are lots of things we put in our body, food and other kind of things that work. And so I don't know what to make of that. And then there are some people who are feeling that this is some kind of government conspiracy. You're going to get implanted with a microchip. There's no data behind that, but I'm not sure that I can convince people otherwise. So my hope is that many of the people who are not wanting to get the vaccine now are wait and see people, and that once they wait and see that this is a safe and effective vaccine, they'll get it. So Carmen says, once a person is fully immunized to the virus, can that person still carry the virus as an asymptomatic person and give it to someone else? And the answer is we do not know, because the studies to approve these vaccines did not include that in their study. The way we would know this is that there is a lot of people now who got vaccinated, and that somebody will do a study where they culture or do that, and they will see if they carry this virus. To date, I don't think anybody in all the world has shown that you can culture a live virus from somebody who has had the disease and is asymptomatic. And certainly many people have tried, but we don't have any positives yet. So it could happen, but I would think it's quite rare. Now, there are some studies of people who have gotten one vaccine and gotten the disease. In fact, I saw a story the other day that somebody who got 2 doses and should have been immune wasn't. But again, remember, the immunity was 95%. It wasn't 100%. And so 95% means 1 person out of 20, the vaccine doesn't work for whatever reason, and they are susceptible to the disease. So Paul says, why are other counties like Deschutes getting so many more doses than we are? This is a complicated technical issue. So smaller counties got more doses per capita than we did because early on the distributions to counties were in blocks of 200. So if you were a county with 1,000 people and got a block of 200, that was a lot of vaccine, right? That was 20% of your population. In Douglas County, 200 doses was nothing, right? It was less than 1% of our population. And so early on, some of the smaller counties had really high levels. And that was because these vaccines come in boxes of that are not supposed to be split. And so the minimum you could send was 100. And so they sent 200 to each of the health departments. And that's why some of the smaller counties you'll see have these really high vaccination rates because they got 200 or 400 doses. And that is a high population of their county. The other thing that happened is that early on, it was an incredible push to get as much vaccine out as possible. So the state worked with some large hospital systems, and there are 6 large hospital systems in the state. There's Portland, there's a bunch in Portland, but Portland, then there's Salem Health, then there's Samaritan Health, then there's Peace Health, Asante, and St. Charles. So early on, when they wanted to get a lot out, the state worked with the large hospital systems to give them lots of vaccines. So you probably heard about Salem Health doing this thing at the fairgrounds. Similarly, St. Charles Health System, which is a big system in Deschutes, really sort of takes care of everybody east of the Cascades, got a lot of doses. So they got 17,000 doses in one weekend. And so what happened is Douglas County was sort of in the worst situation because we had a relatively large population and those 200 doses here and there did make a big difference. And we don't have a big system. So CHI is a big system, but not a big system in Oregon. Actually, Douglas County has got far and away the biggest CHI thing. So they didn't get involved. So because we did not get the high number because we're a small county or have a big system, we really got the lower amount. So I talked to the person who's doing head of allocations. They totally understand that, and I think we have worked on fixing that, and I think that's going to get fixed over the next bit. Tracy says, does taking Tylenol before the vaccine affect the efficacy? So there's been some of these studies done in kids, right? We give a lot of vaccines in kids, and we do a lot of antibody studies in kids. There's a suggestion that anything that you do that affects your body's immune response could decrease the effectiveness of a vaccine. Remember, the reason you get fever with a vaccine or the reason you get fever with an infection is not actually from the virus itself. So it's not the virus that's giving you the fever when you get the flu, or the bacteria that's giving you the fever when you get strep. It's your body's immune reaction. And there's been some concern that if you blunt that immune reaction by decreasing temperature, you'll have a little decreased effectiveness of the vaccine. In pediatrics, it's not enough to make any difference, so we allow people to use this. It has not been studied. It has not been studied with COVID. So Patty says, my mom's 80 and has no doctor. Where can I take her on February 8th? First and most important, if you're 80 years old and you don't have a doctor, that's tragic. I mean, at 80, things go wrong, and you really should have somebody you know and trust to take care of you. The plan for seniors is going to be published on Friday. It's going to be in our daily press release. It will likely be in the newspaper. And we're going to spend all of Friday's Facebook session going through that plan. We reviewed that plan today with our vaccinator group in the county. We reviewed that plan actually with the governor. We reviewed that plan with the commissioner. We've reviewed that plan with the board. And so we're ready to publish this on Friday. So this is a teaser to have everybody join us on Friday. So Veronica says, where are the school outbreaks? I know the one in Green, but where else? Really everywhere. I mean, they're in pretty much, they're 13 or 14 as of this morning. They're scattered throughout the county. I'm trying to think if there's any school district that hasn't had one. I'm not sure there is. They're just scattered throughout the country. And again, when we talk about outbreaks, in schools, it's a single case, right? So, for example, we had one previously where there were a family was sick, 2 kids in the family got sick with COVID, and that was considered to be 2 outbreaks because each of them were in different classes. No further transmission, and that's the kind of thing that happens. So kind of all overall. So Denise says, are there any concerns with trying ivermectin? Not that we know of. I mean, we use ivermectin for other things, stuff like head lice. Your dogs use ivermectin for heartworm. We think it's relatively safe and effective. But again, the story is, we don't want people to do all these trials with one person. I mean, we have 200,000 cases a day. It would take only a week. I mean, because we're not, so some drug studies are difficult, right? Like if I take cholesterol, will this prevent a heart attack 10 years from now? Or if I take, if I take this blood pressure medicine, am I going to have less death over 20 years? Well, it takes 20 years to do that study. And in 20 years, people move, they drop out of the study and whatever else. And so it's really hard to know. With these things, in a week, right? It doesn't take more than a week to know. And so my call in this is that somebody should do a great study with ivermectin. Find 1,000 people, give half placebo and half the other drug. At the end of 2 weeks, you break the code and you figure out whether it worked or not. With 1,000 people in each group, you will know in 2 weeks whether it worked or not. And this is my cry. Why in the world haven't we done this? Well, the problem is a great article in the New York Times early this week, and basically the trouble is that the U.S. has a very, very, very rigid system for doing drug studies. They have to go through investigative review panels. They have to go through all kinds of stuff to do studies on drugs. And unfortunately, it takes so long that these drug studies just haven't gotten done correctly. And that really is a pity, because I'd really like to know if ivermectin worked. I mean, let's say it really did. Let's say it's as good as this guy in Wisconsin says. Wouldn't that be great? I mean, wouldn't it be great for it to decrease things like that? I think not, though, right? Because when you look at his hospital and the area around it, just as much disease as everybody else, right? So if this was really the magical miracle drug, you would think his hospital would just have very few cases, because a lot of people were on ivermectin. You don't see that. You remember there was a person from Texas early on who suggested inhaled corticosteroids were a miracle drug, that it basically prevented any progression of disease. And this guy was pretty convincing. He had this YouTube channel, and I watched a bunch of this and thought, well, it's pretty convincing. Well, it's been studied and it doesn't work. And so, again, this is my concern as a provider, right? So I'm a doc. I mean, I can't do this study. I'm not going to have 2,000 patients with COVID. I couldn't do this study. But, I could get, if it's an area like Texas or California or Wisconsin with a lot of cases, there would be a way to do that study where you'd say, we're going to give you, you've been diagnosed with COVID. We're going to give you a pill to take. We're not going to tell you which one it is. And then in 2 weeks, we're going to see. And in 2 weeks, actually the only place that's done that study correctly is the one that used Luvox, which is this drug that we use to treat obsessive compulsive disorder, which was suggested in France to be important because people were taking it seemed to get less sick with the disease. And then what they did is they found people who were diagnosed with the disease. On the day they were diagnosed, they gave them a little goodie bag that had a thermometer in it and Gatorade and stuff, and it had pills, and it said, if you want to be part of the study, take the pill, and at the end we'll tell you if you got the placebo or the real pill. And the people who got the Luvox, none of them got sicker, and the people who took the placebo, the expected number, got sicker. So that was a good way to do the study, and within 2 weeks they got it, statistically significant, totally believable, published, and I think the evidence for Luvox is quite good. They could do the same with ivermectin, and they should, and that's my cry. So Steve says, I'll be due for my second Pfizer next week. Is that going to be available? Yes. So we think right now we're on track with second doses. Again, on the second doses, it says you should get it 21 days. But none of these say it has to be at 21 days. They're all 21 to 42 days. The Moderna is 28 to 42 days. So you don't have to worry about getting it on the exact date. So Vicky says, I'm in group 1A, group 3. When can I get my vaccine? Well, the organ sequencing plan is extraordinarily complicated. It's 13 pages with dozens of footnotes, all kinds of ins and outs and whatever. And so There are a lot of people who say they're covered, and when you look, they're really not. There are other people who don't think they're covered, but they really are. So it's a very technical determination whether you're in or not. But if you really are in Group 1A, in Phase 1A, Group 3, you can get your vaccine now. And again, if you're in Phase 1A, you should send a note to vaccines@douglaspublichealthnetwork.org. Again, vaccines@douglaspublichealthnetwork.org. One of our staff members will look at the request, and if indeed you're in that, then they'll hook you up with a provider who has vaccines. So we sent 20 or so today to one of the clinics in town. We had 20 requests today. They were in 1A. We sent them to a clinic in town, and they'll get vaccine. However, the problem is the state has a ridiculous website that basically asks 3 questions and then tells whether you're covered or not. Well, I mean, it to me is absolutely maddening, because the guidance they sent out is, again, 13 pages, dozens of footnotes, references, and whatever else. And it's very technical about what's covered and what's not. This has 4 questions and it thinks it could do the same thing. So there's frequently where we'll disagree. You know, the state will say, yeah, the state little bot thing will say you're covered, and it's very clear you're not. And then other times when the state bot says you're not covered, and you very clearly are. So I wouldn't trust that. But again, if you think you're in Phase 1A, Group 3, you can get your vaccine now. Please send an email to vaccines@douglaspublichealthnetwork.org. So Jessica said, the day after my first vaccine, I had bad flu-like symptoms. I hear the second is worse. Is it necessary to take the second dose? So 2 questions here. So the first one is about having a bad reaction. Yeah, the second reaction does seem to be worse. Again, remember, this is your body making an immune response. The first time, presumably, it's never seen this virus, so it makes an immune response. A month later, when you get the second vaccine, it goes, wait a minute, I remember that. So it makes a stronger response, so not surprising that you might have more symptoms the second time than the first. And in both the Moderna and the Pfizer trials, that was indeed true. I'm scheduled to get my second one on Thursday, so I'll let you know on Friday how I feel. The second question, is it necessary to take the second dose? Well, I will tell you, there's a brisk worldwide discussion about the second dose. When you look, it appears that you get about 80% protection from the first dose, and then that climbs to 94% after the second dose. So clearly the second dose helps. But the argument that many have made, including Dr. Wachter, who's I think the smartest guy I ever met, Dr. Osterholm from Minnesota, is maybe what we should do is, instead of using all those second doses for second doses, you should get more people get their first dose and then wait and do the second dose later. That's what they do in Britain. That's what they do in Israel. We're not doing that yet in the United States, but who knows what's going to happen. Is it necessary to take the second one? Not absolutely necessary. We think, again, you get about 80% of your protection from the first dose. So Melody says, what are the logistics for maintaining storage requirements for vaccines in the county? So there are 2 different vaccines now. There's the Moderna vaccine that requires frozen storage until it's defrosted, and then refrigerated storage after defrosted. That's relatively easy to do. I mean, we all have freezers and refrigerators. It doesn't require anything super special. The other one, though, is the Pfizer. That requires dry ice kind of temperatures for storage. And so for that, we have 3 places in the county where you can store that. The problem now is not enough storage. We have all of these super cold freezers. We don't have any COVID vaccine. We've not gotten any COVID vaccine in 2 weeks. So we've got these big expensive freezers and nothing to put in them. Now, that may change. The Pfizer vaccine may become more available. We were told that the Biden administration bought 200 million more doses, so maybe it'll become more available. Right now, the problem is not the storage. The problem is the vaccine. So my friend in Jackson County was just diagnosed with COVID 2 weeks after her first vaccine. Should she skip her second vaccine? I would certainly have her talk with her doctor about that. Again, our recommendation has been that people who had COVID should not. So Anybody who's had COVID can get the vaccine at any time, so that's not a contraindication. Although my recommendation has been, with the vaccine being in very short supply, if you had the disease last week or 2 weeks ago, you're very unlikely to get reinfected in the first month, and basically you might wait, let somebody else who needs to get the vaccine, and then get the vaccine 3 months later. But in this person's case, I would certainly have her talk to her doctor. So Amy says, is it beneficial to do titer testing at the first vaccine? Not really. There's nobody who's recommending titer testing. We've done a few. People just want to know when we've done it, and they've gotten titers. The only diseases that we really do titers, vaccines that we do titers for on a regular basis, are hepatitis B. Because it's a workplace issue, and we want to know that people are going to be working in the workplace around blood have adequate hepatitis B titers. The other one that we do is rubella, which is German measles. Rubella is a disease that if moms get it when they're pregnant, they can have babies with really pretty severe problems, including blindness and deafness. So really things you want to avoid. So we do titers on moms, called rubella titers, before they're pregnant. But other than that, we generally don't do titers. The problem is that they're not all that predictive for COVID, because we know some people with low levels of antibodies will never have disease, and some people with even higher levels do seem to get the disease. So it's a really is not recommended. So Laura says, why are people feeling sick after the second dose? Well, the reason they're feeling sick after the second dose is because your immune system is working. Your immune system is recognizing that mRNA is recognizing the protein that mRNA is making and is building antibodies to it. And when your body is fighting anything, making antibodies to anything, it'll give you fever and achiness. So the reason people are feeling sick after the second dose is because it's working. What they found is that although this was a placebo-controlled trial where people in the control group and people in the placebo group were given a vaccine, they didn't know which it was. I know about 10 people were in trials, and all the people got the disease says, oh, I know I got it. It really hurt the next day. All the people in the placebo group said, it was nothing. I didn't even feel it. And then it got broken, and the code got broken, and everybody knew which group they were in because of the reaction. So the reason people feel sick a little bit after the first dose and more after the second dose is because your immune system is working. So Beverly says, my dad is over 75. When is he eligible for the vaccine? What group is he in? So the groups are complicated. So what I'll tell you, dates are easier. So starting on February the 8th, we're going to do people 80 and above. Starting on February 14th, Valentine's Day, actually the next day, we're going to start on people 75 and above. The next Monday, we're going to start on people 70 and above. So he can get vaccine anytime after February the 14th or 15th. And so rather than doing the groups, it's much easier to say what date by ages. Because once you start now getting into once you start getting into phase 1B, group 3, subgroup 4, it gets ridiculously complicated. All right, so a couple of other things while she's getting more questions here. Really a sobering article in the Atlantic today, and it looks at a place called Manaus in the Brazilian Amazon. Now, this place had a lot of disease early on, and they thought, well, we had a tremendous amount of disease. About 75% of us have antibodies. We're going to be done with this. And now they're having a second wave with the Brazilian variant causing lots of bad disease, lots of hospitalizations, and lots of deaths. So that is very worrisome about both second infections and about this Brazilian variant. We're seeing more cases of this multi-system inflammatory disease in children. You'll remember these are kids who weeks after a peak in disease, they may not have had any symptoms at all. 4 to 6 weeks after the peak in disease, they begin to have this severe inflammatory reaction with high fevers, swollen tongues, inflammation of body systems, can really get very, very sick. And in fact, some of those kids have died. And so not surprising, we had a big peak of diseases in December and early January, and now we're starting to see a peak in this multi-system inflammatory disease in children. And they treat this with immune globulin, IV immune globulin, and steroids, and these kids seem to do better with that. That is, again, not surprising because that's how we treat kids who have Kawasaki's disease, which is a very similar disease. And then the other thing that we want to talk about is new vaccines. So the two vaccines we have out now are the Moderna and the Pfizer vaccine. Those are mRNA vaccines. Those are mRNA vaccines. They are a new kind of vaccine. They're making them as fast as they can make them, but it's a complicated process to make them. So they're going to be in limited supply. But there are two other vaccines that are out there. There's one made by Johnson & Johnson. So Johnson & Johnson is a big company, makes Band-Aids and lots of other things. And they have a pharmaceutical group called Janssen Pharmaceuticals. They've had a vaccine which is based on a weakened human adenovirus. It's been tried around the world, and it appears to be not quite as effective as the Moderna or the Pfizer vaccine, but pretty darn effective, still in the 80% range. Although, interestingly, less effective maybe against the South African strain. And so that is probably going to come up for review in the next few weeks. That'll be a good one. That'll be relatively easier to make, relatively cheaper to make, and much easier to store, and as a single dose. So what we're hoping is over the next few months that in addition to the Moderna vaccine and the Pfizer vaccine, we'll have the J&J vaccine. The other one is the Novavax, which is a very old kind of vaccine technology. Basically what you do is you make the protein in yeast cells usually. So you make the protein in yeast cells. You now train yeast how to make these proteins, and then they churn out the protein. And then you inject the protein, in this case plus a thing called an adjuvant, which increases the immune response, and you see how it works. This is kind of how we do most of many other vaccines, including hepatitis A and hepatitis B, and it seems to work well. The Novavax vaccine also didn't work as well against the South African variant, but again, pretty effective, relatively low rate of side effects. So it is possible by the time we get to April or May, we'll have 4 different vaccines to choose from, and that would be great. So Dale Ann says, should people who do not get a reaction after the vaccine worry it's not working? No. That was my group of 10. I mean, I got the vaccine. The arm hurt a little bit. I tend not to get a lot of reaction to things. So if I get a tetanus shot or a flu shot, I barely know it. So I wouldn't worry too much about that. But in general, people after the second dose, after getting the vaccine, they know they've gotten it. So Casey says, why is there not more DNA sequencing done to determine variations in the U.S. compared to other countries? Well, it's because we've not had a national strategy to do that. So the Brits and the Danes have had a national strategy to sequence things. In the U.S., there have been people doing it, but nobody in a standardized fashion. So in Oregon, the universities are doing it, and the University of Washington is doing it, but in no reasonable standards, no kind of standardized way of doing it. They say in Oregon, in the U.S., we're doing about 1 in 300. The Brits are doing about 1 in 10, and the Danes are doing everyone. And so it really is shameful that we're not doing more of this. But what I tracked that down to was no strategy. I mean, we have plenty of DNA sequencing stuff in the U.S. In fact, we think we have more ability to do DNA sequencing than anywhere else. And it's not DNA, these are RNA viruses. But we have more ability to do sequencing, and that we've not gotten around to it is just shameful. I don't think there's any other way to put it. Okay. So again, this is a teaser for Friday. So on Friday morning, we're going to publish our vaccine plan for seniors. We're going to talk about it Friday afternoon here. I'm going to talk about it next Monday on KQEN. So we're going to have plenty of information about doing the vaccine. The only thing I'm asking people is to just realize we have a plan and it's coming. This is not going to involve huge lines or or complicated signups where you have to get up at 4 o'clock in the morning so you can be first online to get a ticket. We're not going to be doing that for seniors. It's going to be, I think you'll find a plan which is going to work out well for our seniors. So again, Friday at 4 o'clock. I think pretty much we'll start off with a few minutes of that, but we'll really leave the rest of for describing what we're going to do and for answering your questions. Now, the biggest problem in our senior thing is going to be not enough vaccine. And so we think in Douglas County, there are 30,000 seniors. So again, 30,000 seniors. Of those 30,000 seniors, we think about 60% of seniors will want this. We think there have been maybe 1,000 or so vaccinated, either because they're seniors and they still working like me, and they get a vaccine because they're still working, or they go to the VA and they get it there, or they're in a nursing home and they get it there. So we think some have already gotten it. But by the time you take out the people who don't want it and the people who've already gotten it, we still think we have about 20,000 people in that group who are going to want vaccine. Now, our vaccine allocations for new doses has typically been between 1,000 and 2,000 a week. We have never gotten more than 2,000 a week in new doses. Never. And so maybe we will, but we've never gotten that before. So if we get even 2,000, which would be hopeful, 20,000 people, 2,000 doses a week, even I can do the math, that's going to take 10 weeks to get through all of those. And that's assuming that there's not other new people who are eligible in phase 1A or in teachers. So it's going to take a long, long, long time to get there. Now, the hope is our vaccine allocation will go up. I hope, but it can't go up that much because our allocation from the feds is not going to go up that much. It's going to go up a little bit, but it's not going to go up that much. And so what we're asking is that people recognize that I can't do anything about the supply of vaccines in the U.S. What we can do is about how we're going to give it, and I think people will be pleased with the plan we have come up with. So again, Friday, 4 o'clock, we'll do it here. If you're looking Friday, the press release, you'll see it there. And then Monday next on KQAN at 12:30, you'll see it there. All right. Well, if there's no more questions, we'll call this a wrap. I'll get to any questions that she wasn't able to copy down here tonight. And then we'll see you on Friday. And Friday, we're going to be talking about vaccines for seniors. Again, this is Dr. Bob, the Public Health Officer of Douglas County. Be safe and be kind. Thanks.